And then we added one more movement, which is not the shoulder, but is also part officially of the brachial plexus, which is elbow flexion in the supinated position, which is the musculocutaneous biceps muscle. So what we're going to do today, we're going to focus on the three main nerves that come off the brachial plexus. And again, I highly recommend thinking in terms of movements, because that's what you're going to see in your patient, right? So the movements that we're going to talk about are, again, we're going to talk about elbow flexion, this time not in the supinated position, but in the pronated position. We'll talk about that. We just started, so basically it was.
But we thought it's in the other building, like the old one.
Okay. So what we're going to do is talk about the ulnar radial and median nerves. And what I was saying is that I highly recommend thinking in terms of movements. Last time we talked about movements of the shoulder. We talked about adduction, flexion, extension. We talked about external and internal rotation. And then there was one movement that was brachial plexus, but was not the shoulder, which is the elbow flexion. So those of you that came in, that's what you missed. So we're all on the same page now. What we're going to do today is talk about the rest of the upper limb movements. So the movement that we have left are one more type of elbow flexion, which is in the pronated position, elbow extension. We have two new movements that we have to think about, which is pronation and supination. And then we have movements of the wrist, which is the flexion extension, and then movements of the fingers. Here, there are lots of movements. The most basic one which you should do in all examinations, just for simplicity right now, is finger abduction and adduction. There are more movements that we're going to talk about today, but you don't necessarily have to do all of those in the general exam. So in the general exam, do the movements that we talked about, the shoulder, the four movements of the shoulder, then external and internal rotation, the movements of the elbow, movements of the wrist, and then opening and closing the fingers. So let's put some meat into the okay. So back to your nightmare diagram, which is the brachial plexus. But now we're actually graduated all this spaghetti, and we're going to focus on the median, ulnar, and radial nerve. So let's start with the easiest one, which is the ulnar nerve. And why am I saying easiest one? This. The ulnar nerve comes down from the, if you remember, the lower trunk medial cord. So CAT1 becomes the lower trunk, continues as the medial cord. And why am I saying this is the easiest nerve to remember? Because everything that goes into it is either from C8 or T1. That's it. That's all you need to remember. C8 and T1. There's no other contribution to the ulnar nerve in normal people. Okay, so CAT1, that's what we have to deal with. Okay, so here we have a schematic representation of the ulnar nerve. I try to use most of my schematics from the booklet that you should all have, the aids to the examination of the nervous system, that you should walk around with it wherever you go, and use it on all your patients. So this should be familiar to you guys. So the ulnar nerve basically is not only simple, it's pretty boring the whole way until it reaches the elbow. In the elbow, there are two nerves that come off the ulnar nerve. One that is the flexor carpio-ulnaris, which is the main muscle which flexes the wrist in the ulnar aspect. So over here, you can feel the tendon. So when we flex the wrist, what we'll see is that in the flexion, we actually have contribution of two nerves. We have the ulnar contribution, which is responsible for the activation of the FCU, the flexor carpio-ulnaris, and in a moment we'll see activation of the radial aspect, which is different from the extension. Extension is all done by one nerve, but the flexion, we have contribution from the ulnar, and in a moment we'll see that the median contributes in the radial aspect, okay, the lateral aspect. What does it mean? It means that if we have weakness, if we have ulnar neuropathy, then we'll have difficulty flexing the wrist, but it will have a deviation towards the stronger side. Okay, so this will be weak. We'll be able to overcome it as the examiner, but what will be stronger is the FCR, the flexor carpio-radialis. Okay, because we have separation of the flexors of the wrist. Okay, we'll see the mirror image when we get to the median. Okay, so it's important to know that flexion is done by two nerves, separate nerves. But this is what this is. So that's the FCU. The FCU has another importance, which is more anatomical, we'll see in a moment, and that's the actual relationship of the nerve and the muscle. The nerve passes below the muscle, and that can give us pathology from compressions, for example. We'll see that schematically in a moment. So those are kind of the two main reasons to remember the FCU. Then we have another branch here, which is the branch that goes into the flexor digitorum profundus, which basically does this movement here. So when we have ulnar neuropathy of the elbow, this movement, just of these medial digits, will be impaired. The flexor digitorum profundus on the lateral side is activated by a different nerve, which we'll get in a moment. So this is the flexion of the digits. Okay, so now I want to introduce another term, which sometimes people find a little bit confusing, and that is extrinsic versus intrinsic hand muscles. Okay, so when we activate the hand, when we activate the fingers, actually we have two types of muscles that do it. We have muscles that are within the hand that do it. Those are the intrinsic muscles. And then we have muscles that are not in the hand, but control the hand. Those are muscles that are extrinsic, okay? So the FDP is an example of an extrinsic muscle, okay? So if you come across that term, that's what it means. Is it within the hand or outside the hand? Okay, oh, sorry. Now, basically, that's all that happens with the ulnar nerve until it reaches the wrist area, where all the action happens, because what you should know is that the ulnar nerve is the main player in the activation of intrinsic hand muscles. We gave an example of an extrinsic hand muscle, but that's just one. The rest of the ulnar nerve is really responsible for the movements in the hand, within the hand. And one that I recommend most commonly tested is the plantar and dorsal interosseous muscle. So the dorsal interosseous AB abducts the fingers, basically separates them, and the palmar interossi puts them together. When you do it, please make sure you take away gravity. You put the hand of the patient on their thigh, on the table, and let them do it like this. Otherwise, you may be fooled by contribution of extensors, which is a different nerve, which may compensate. So basically, if this is confusing, just remember, when you test those movements, just make sure that the hand is leading. Okay, and then later check why did you do that. But just remember, always put their hands on the thigh or on the table, and then ask them to do those movements. Okay. Now, what I did do is lie to you, and I said that nothing happens between the elbow and the wrist, which is not completely true. It's true in terms of motor, but it's not true in terms of sensory. Here we actually have a sensory nerve, which us EMGers love. We affectionately call it the duck. What's up there? But it's actually the dorsal ulnar cutaneous nerve, which is responsible for sensation in the dorsal aspect of the hand over here. Now, why we love it so much? The reason is, if you notice, it comes off before the wrist. Okay? Now, in a moment, I'll tell you that the two most common pathologies of the ulnar nerve are either in the elbow, here in the elbow, compression of the nerve in the elbow, or compression at the wrist. In terms of the weakness, or in terms of how the hand will appear, it will appear the same. So us EMGers, you love to test this nerve, because if it's involved, right, we compare two hands, both hands, if it's involved, then we know that the lesion must be above, proximal to the wrist, because the takeoff is between the elbow and the wrist. So remember the duck. Dorsal cutaneous branch. Also, you can test it in the pinprick. If a patient has sensory loss in this area, this cannot be a problem from the wrist. It's causing compression of the ulnar. Okay. All right. Now, going back to, if you remember in the last talk, we talked about the fact that the inner aspect, the medial aspect of the arm, in the forearm, in terms of sensory, they are not supplied by the ulnar nerve. This is a very important concept. We talked about the nerves that come off directly from the brachial plexus and supply the sensory aspect of the medial arm and forearm. And we said that that's important because if you truly have sensory loss over there, that's not good news, because that means that there's a lesion in the axilla here, compressing or causing damage there. And that's never good news. That's typically, it would be cancer. Okay. So remember that this area here, the sensory supply, is not from the ulnar nerve. The ulnar nerve, and here you can see it, supplies in terms of sensory just this aspect here. So we have 1.5 fingers, both palmar and dorsal aspect of the hand. Both palmar and dorsal aspect of the hand. That's it. That's all what the ulnar nerve supplies in terms of sensory. Now, again, I want to emphasize, it doesn't mean that if you can have pain along the ulnar nerve. All of us know that if you hit the ulnar nerve in the funny bone, it hurts. But it's not an area of sensory loss. You'll do a pinprick exam, and you have ulnar neuropathy. The only location that you may expect to have sensory loss will be in this region here. Okay. Basically, what I'm trying to say, if you have pinprick sensory loss over here, it's not just the ulnar nerve. There must be something else. All right. Now we're going to talk about one of the two most common areas of pathology to the ulnar nerve. The most common one is at the elbow. And there are lots of pathologies that can be in the elbow. We already said earlier, here's the famous FCU, flexor carpi ulnaris, where there are two heads here, and they're connected by connective tissue here. And this connective tissue here may compress on the nerve. And sometimes in some people, the pressure is so high that they get an ulnar neuropathy, and then we find it in the EMG, and we ask the surgeon to do something, or not always you need to do something, but sometimes what they can do is very simple surgery to basically open up and make a cut here and release. They can release the nerve. That's just one example. There are many other problems that can happen in the elbow, but that's just one example. This is a very common location for a problem. There could be also dislocations of the nerve. It could pop out, in and out. What I didn't mention is where to find it. So actually, you can find it on yourselves. It's between the olecranon and the medial epicondyle. So those are the two bumps here, right? And you can tap in between them, and you can actually do the Tinel sign of the ulnar nerve. We'll see in a moment. The classic Tinel sign is for carpal tunnel, but Tinel basically recommended just tapping on nerves and to see if there's pathology, and you can do that over here as well. So in a patient, in anybody, it will cause discomfort. But if you have ulnar neuropathy, they will be even more sensitive. Okay. Now, what are the things that when we do have ulnar neuropathy at the elbow, basically everything below that depends on the level of damage. But if there is compression, or let's say there's trauma or anything that happened in the elbow, basically everything below that could be impaired. So we already mentioned the couple muscles that are involved that are right there at the elbow, so they may be involved, depending if it's above if the lesion is above the takeoff or not. So we can have weakness of the flexion of the wrist, we can have weakness of the flexion of the fingers, and then we can have all the distal problems, which is the intrinsic hand muscles, and basically we will see difficulty with opening and closing the fingers. Okay, there are also kind of classic postures that the patient will have. One of them is kind of the Benedictine posture, where they'll have weakness of the fingers and they won't be able to move them. Notice also that the fingers are kind of a midline separation. They can't really separate more, but they can't actually bring them together. So it's kind of a posture that if you see this, this is kind of very suggestive of ulnar neuropathy. Now here, I don't remember if actually those of you who were with us last year heard me give the talk about the nerve conductions. At some point we'll give the talk again, so those of you who joined us will hear the basic concepts of nerve conductions. But here's just schematically what we do in EMG lab. So we have here what's called compound muscle action potentials. It's a mouthful of, but basically what it means is that we put electrodes on a muscle that is innervated by the, in this case, the ulnar nerve. So in this case, we put it on the AEM, you don't have to remember that name, but it's a muscle that's innervated by the ulnar nerve. So we put electrodes here. And then what we do is we stimulate here, and we stimulate here. So 3 locations. We can also stimulate in the axial. Usually when us, when Jakob and Ziska and I and Nuri, we usually will do 3. So we'll do in the wrist, below the elbow, and above the elbow. Now, as you may remember from physiology, it really doesn't matter to the action potential that you record from the muscle where you activated the nerve. because it's an all or none function. It's not like if you're further away, it's going to be lower. No, it's going to be exactly the same. It doesn't matter. You activated the nerve here, here, or here. So what we expect is that the hump here, no matter where we activate it, will be at the same height. So in this case, we have the red, which is wrist, blue, which is below the elbow, and then look what happens to the action potential when we move the stimulator above the elbow. So what does it tell us? It tells us there's some blockade here or some pathology here that caused the term that we use as a key conduction block. Conduction block is when we have the action potential here drop below 50% from the original. So that means that there's a problem between the stimulation site here and the stimulation site over here. And we can actually be even more precise. When I used to work at, for your time, we actually had a third center, which is in Brooklyn Hospital. We worked very closely with an orthopedic surgeon. That was his specialty, the elbow. He used to ask me to localize even more where the lesion is. So then he doesn't need to open the whole elbow. So we do what's called inching. So we already know that below the elbow, we get a normal action potential, and above the elbow, we get a lower. But then we can also do inching, and then with measurements in relation to the medial epicondyle, I can tell him, look, the drop is exactly 1.5 centimeters below the medial epicondyle. So then they know where the problem is, and then if there's a fibrous tissue over there or something like that, you can open it and just cut it, and usually the patient actually benefits from it. Any questions about this? All right. Now we're getting to the second location where the nerve can be damaged, and that is at the wrist. Less common, but there are some people who are susceptible to this problem. One of the groups that is most susceptible is athletes, of all people. People who lift weights, for example, and if they didn't invest in $10 or $7 of gloves, over time, especially if they're good and they bench press high weights, what will happen is that they'll press on where the nerve goes into the hand, which is through the Guillain canal here, which is between the hamate and the pisiform bone over here. It's called Guillain canal. If you push on that area, then you may have ulnar neuropathy, which will involve all the intrinsic hand muscles, except those that are innervated by the median nerve, which we'll get back to that, but the majority of the hand muscles. We also can see it in people who cycle for long distances, but as those of you who cycle know, it's the same as the weightlifters. The recommendation is always to use gloves to pad the pressure on the ulnar nerve. In the past, we used to see also in conductors this problem. And actually, I actually remember when we came to New York, it was over 20 years ago, in the what's it called? The Hudson Valley. The north.
The Long Island.
No,
Oh, the north, yeah, the north.
yeah, not the Long Island, not
Okay, that's the-
the one that goes up. I
Yeah, which one
remember
are-
distinctly, the guy was going around in the whole train, and just every half hour he came and he did this and put a hole in our ticket, which he already did like 7 times before. And that obviously, I was thinking, yeah, this guy, if he doesn't have already, he's going to get ulnar neuropathy at the hand. Which is no longer a problem, everything is scanned, so it's all computerized. But that used to be a problem, because if you think about it, if you cause pressure thousands of times a day, every day for several hours, ultimately you'll have pressure pulse in ulnar neuropathy. Over here. So basically, you can, it depends where the lesion is. The more proximal it is, the more muscles will be involved, including the feeder muscles, all the adductors, and essentially the older distribution. Now, very important is that ulnar neuropathy can masquerade. Ulnar neuropathy in itself is not dangerous, whether it's in the elbow or the wrist. Yes, there's surgery. Sometimes you need surgery. The patient suffers a lot of pain, but usually it's not deadly. What you don't want to miss is a deadly cause of what may appear as ulnar neuropathy. And the thing that we really are concerned about when we see a patient come in with a hand like this and atrophy of the muscles is what goes into your mind when you see that in a patient. What goes to your mind when you see a patient like this with atrophy of intrinsic hand muscle? And they tell you it's weak and it's going weaker and weaker.
Thoracic outlet.
Could be thoracic outlet. It's kind of rare. Usually not deadly, but what will be deadly causes?
Pancreas tumor, pancreas tumor.
So pancreas tumor, yes, affecting the lower trunk, right? Or
motor neuron disease.
motor neuron disease, right? So I've seen with my own eyes people who are diagnosed with ulnar neuropathy and turned out to have motor neuron disease. But in the beginning, you don't know because every disease starts somewhere, and it could appear in the beginning as ulnar neuropathy. The kicker is that it's motor only, right? So you really study the patient, but as you know, you study patients. Sensory is sometimes misleading, and sometimes they do have symptoms that are sensory, which are unrelated. So basically, think about it. Don't give a diagnosis of ALS for a patient who has ulnar neuropathy, but just put it in the back of your mind. Could this be more? So look at the patient, see if there are fasciculations elsewhere, ask them if they have weakness elsewhere, look at the other side, and so forth. Another issue is radiculopathy, which also can cause weakness and distribution of the ulnar nerve. But as we'll see in a moment, although ulnar nerve is only CAT1, not all CAT1 nerves or roots go to the ulna. Okay, so we have CAT1 go to the median. Also, they may contribute to the radial nerve. So if we have weakness, which in a moment we'll see of other muscles that are beyond the ulnar nerve, you have to think, oh, maybe it's not ulnar nerve, maybe it's more upstream, maybe it's radiculopathy. Did everybody follow what I just said? Okay. All right, so ulnar nerve was easy, now radial nerve. So radial nerve, if you remember, comes from the posterior cord, which is interested in the arcs, right? You remember? There are four major nerves that come off the posterior cord: the axillary, the radial, and then we have basically the pair of the subscapular nerves and the thoracodorsal. Okay, so ARTS, ART, and the two S's. And now we already talked about the A, the T, and the S last time. So now we have to talk about the R, which is the radial. So it's a continuation of the posterior cord. Again, it's important to remember the relationship with the axillary artery, which lies right above it. So remember, if you puncture the axillary artery and you get blood, but you insist on going further in, then you may hit the posterior cord or the radial nerve, and the patient may have a wrist joint. So remember the relationship over here. So when you go to the neuro ICU and they ask you to do an arterial line in the axillary, just remember the moment you get blood, don't push in. Okay. All right, so here's the radial nerve. The radial nerve does have branches off very proximal. And those branches are the ones that are responsible for innervation of the triceps muscle. And triceps has 3 heads, and they all come very proximal on the takeoff of the radial nerve from the posterior cord. Now, why is it important? It's important because if you do have triceps weakness, which is responsible for extension of the elbow, remember thinking about movements, we're introducing another new movement here, extension of the elbow to triceps. If you have involvement of that, that means that the problem, the pathology, must be very proximal. You cannot have a fracture of the humerus here, more distal, which is actually very common location, causing triceps weakness. Now, this is again one of those things that is important for life and important for the boards. I don't know if I should keep on saying it, but that's an example of an exam question that you may see. That is in the back. Right, so involvement of elbow extension, which means that the pathology is proximal. But it also means the flip side of it is that if you have compression or let's say one of the most common problems with the radial nerve is compression over here. It's called Saturday night palsy. Intoxicated people who drank too much, for example, and are leaning on their shoulder, on their arm over here, like on the bench. I'm sure you've seen it, and if you haven't, you'll see it. You'll be called to the emergency room to assess if the patient had a stroke. And what will you see? You'll see that the patient has a wrist drop. Okay? And then you'll get the story, and then you'll ask for alcohol level, and you'll be like 400. In those patients, what you really need to do is, aside from assessing all the muscles that we'll talk about in a moment, is assess extension of the elbow. Because if extension of the elbow is involved, then this is not a Saturday night pulse. Then really think maybe they did have a stroke or a subdural hematoma or something like that, something central or in the neck. But it cannot be explained by simply pressure on the nerve over here. Okay, so that's kind of a pro to remember. All right, what else we need to know about the radial nerve? It's very close to the bone, and actually we have what's called a surgical head of the humerus. Lots of trauma and fractures to the bone can cause trouble to the radial nerve, so it's very common kind of lesion. And then there is a muscle here that is very important for us, and also to emphasize a concept, and this is the brachioradialis. Remember, we said that we're going to today talk about movements of the elbow. Last time we talked about flexion of the elbow, but we talked about flexion of the elbow in the supinated position. Remember, in the position that we hold the soup, right? That was musculocutaneous, right? That comes from the upper trunk lateral cord. Now we're talking about the brachioradialis, which is a very strong flexor, but it's in the pronated position. Prone downward. It's in this position. And you can test yourself. Hold your hand like this and try to push up. You'll feel this muscle bulge. But hold your hand like this and try to flex. You'll feel this muscle bulge here. Okay. So when you examine patients, remember that distinction. When you ask them to flex their hands, if you remember the distinction, I'm not telling you always to do that, but remember the distinction. It's different if they do this or if they do this. Because they can do this very strongly, but that doesn't mean their biceps is strong. It's different my biceps. So that's point number one. So remember, in terms of movements, we added several movements already to our glossary today. This is another movement of the elbow. Okay. The second concept about that the brachioradialis reminds us is the general function of the radial nerve. The radial nerve activates mainly posterior compartment muscles. What they have in common is that they're responsible for extension duties. Okay, so extension of the wrist, extension of the fingers. The kicker is that so listen carefully. All extensors are radial. So even if I tell you a name of a muscle you've never heard before, like extensor digitorum pluminis, you don't even know what it does, you know that it's innervated by the radial nerve. All extensors, everything that starts with extensor is radial. The kicker is that not all radial innervated muscles are extensors. And here's the example. So if you're asked which muscle is not an extensor, but is activated by the radial nerve, it's the thing, brachioradialis. It's not the only one, but brachioradialis is an example. So everything that has the word extensor, automatically in your mind, it's radial. But remember that not having the word extensor doesn't mean that it's not radial. So brachioradialis is one. All right, now we come to, remember that we said that in the flexion of the wrist, we have two nerves involved. That's not the case in the radial, in the posterior aspect, in the extension of the wrist. As we said, all extensors are radial. And it doesn't matter if they're extensors that are in the radial aspect or the ulnar aspect, they're all radial. There is a difference though where they come off. So notice that the extensor carpi radialis longus and the extensor carpi radialis brevis are either within the elbow or just above it. Which means that if we have a more distal lesion, let's say a fracture of the bones underneath the elbow, those may be spared. So even though extension is all done by the radial nerve, there could still be a gradient. So what it means is that if we have a fraction over here, for example, below the takeoff, especially the extensor carpi radialis longus and brevis, those could still be strong. And when you ask the patient to extend their wrist, they may have a radial deviation like this, right? Because these muscles still get their innervation. If it's all involved, then you assume it's somewhere here in the surgical neck. Okay? So that can help you distinguish where lesions are. Most commonly, it will be either the humerus, or there's lots of pathology in the elbow. Lots of times, skiers, you just name it, any motorcycle. So it's an area that is kind of prone to fractures and basically be involved, but it doesn't always have to go together. Now, there's something here happens which is very, very annoying, and it's going just to really aggravate us. What happens here is just below the elbow, the radial nerve, the same radial nerve, nothing happens to it except that it changes its name. The radial nerve becomes the posterior interosseous nerve. So below the elbow, and it's actually just at the point below, you see here the branching off the sensory branch, the superficial radial nerve. Below that, the radial nerve, nothing happened to it. It didn't split, it didn't change. All it did is to annoy us, it changed its name. But the posterior interosseous nerve is the radial nerve. Okay? But boy, do people who write boards love this because they're going to use it against you. So just remember, the posterior interosseous nerve, the pin, is the radial nerve. It's exactly the same nerve, it just changed its name. This is not the case, we'll see in a moment, in the anterior interosseous nerve. That's a different story. The posterior interosseous nerve is simply a continuation of the radial nerve. So if you want to ask me why they did it, I don't know the answer. I don't know you. So they can ask another question in the voice. But what's important is that there's nothing here that happened to the radial nerve. Now, in that area, we have another movement that we need to introduce, and that is supination. Remember, we said we want to hold a bowl of soup. That supination is done by a supinator, and that is not an extensor muscle. You can think of it as to some extent extending, but it's actually another rotation more. Supinator, this movement, and it's done by the radial nerve, just below the elbow, just where the radial nerve decided to change its name. All right, and then we have the other extensors, and here we introduce the extensor carpiolaris, so that's for the completion. Remember that the extension of the wrist is all done by one nerve. We have the radial aspect and the ulnar aspect. And then we have all the other extensors, and again, we'll just group them. Anything that have the word extensor is great. Now, I do want to mention this sensory branch here. It's again a sensory branch that we love, us EMGers, and it actually passes through the snuff box over here, so you can tap it. That's also kind of like torturing yourself. So I already gave you 2 tips. You can torture yourself here, but if you get bored of that, you can torture yourself by doing it to now sign of the radial nerve over here. So here and through the snuff box, that's the radial nerve, and it supplies the sensation of the dorsal aspect of the hand. So what is left to us, from the ulnar, remember we said the ulnar is 1.5 fingers here, the rest is the radial nerve, the superficial branch. This is also important. This may be asked, and you sometimes will see it. Those of you who joined the clinic with Yakov, the neuromuscular clinic, there are patients with CMT, patients with Charcot-Marie tooth. In Charcot-Marie tooth, they get hypertrophy of the nerves. It's basically not the nerve, but it's actually the surrounding tissue, to the point you can actually feel it. Okay. So it becomes hypertrophied. So if you see a patient with CMT, try to palpate their snuff box, and you'll feel the cord here. Actually, you can feel it on yourself, but it's going to be so you can practice what normal feels like. So you need normal perforation or leprosy for that matter. Those of you who remember Soma, he used to palpate nerves, and actually made a diagnosis of leprosy in Kings County when he palpated the greater. Anyway. Superficial radial nerve in the snuff box, which is central. Easy to record. Okay, I don't know why I took this figure again. Let's move on. Any questions on the radial nerve? All right, we're doing good. Okay. 5 minutes for the median nerve. So the median nerve is all that's left to us. Now, the median nerve, as you can see, has contributions from everywhere, which always causes a headache. So the median nerve has contributions from the lateral cord and from the medial cord. And the lateral cord, you remember, has supply from C5, C6, C7. And then the medial cord has supply from C8 and T1. Basically, what it means that everything contributes to the median nerve. That's a mess. But here's an important concept. Even though everything contributes to the median nerve, there's still differentiation. The lower you go, the more distal you go, if the muscle is innervated by the median nerve, the more lower it is from the cervical, the lower cervical group contributes to it. Basically, what I'm trying to say is that the forearm muscles that are innervated by the median are going to be more from the upper roots, so C6, C7, C5. But the more distal ones that are in the hand are going to be those that come from C8 and T1. Typically, in a normal person, hand muscles that are innervated by the median nerve are not going to be from the upper roots. 5, 6, and 7, a little bit maybe 7, but usually not, usually for the T8 and T1. So that's one way of differentiating. But in general, just remember that all roots contribute to the median nerve, and the more distal you are, the lower the root. Okay, so here's the median nerve. Now the median nerve, again, nothing happens until the elbow. And then in the elbow, we have a few anterior compartment muscles. Basically, if you stick a needle in the forearm here, chances are that you'll hit a muscle that is innervated by the median nerve. Remember, there was only one that wasn't. That's the FCU. That was from the ulna. All the rest of the meat here is median innervated. Okay. So really, all you have to remember is that all the muscles here are median innervated. So whether it's the flexor carpi radialis, whether it is pronator teres, any muscle here, just remember it's median. And then just remember that because it's more proximal to the hand, it will be more C6, C7. Okay? So if you remember that, you don't even have to remember the specific names of the muscles. Now, there is something here that I ask you to remember, which actually is important. Look at what happens to the median nerve. After it did give us the pronator teres, in this case pronation, and it did give us the flexor carpi radialis. We already talked about the flexion. We talked about the ulnar contribution. Now we're talking about the radial contribution, the FCR, all anterior compartment. So everything that we're saying now is what we said earlier. But here, an interesting thing happened. The median nerve over here, there's a branch that comes off it, and it's called the anterior interosseous nerve. AIN. As opposed to the posterior interosseous nerve, which was invented just to aggravate us, the anterior interosseous nerve is actually a real nerve that branches off the median nerve. Okay, so the median nerve itself continuously straight line goes to the hand. But the branch here of the anterior interosseous is not just simply a continuation of the median nerve, it's an actual branch. And it's an actual branch that is important for us because it causes pathology. And it's also money back guaranteed, a muscle that you'll be asked on in the board. So what does it do? Basically, remember that it does this. This is what it does. Okay. This is what the anterior interosseous nerve does. Basically, you ask the patient, are you okay? Can you do an okay sign? If you do this, anterior interosseous is functioning. It's also what you should probably remember is that it's only motor. It has 3 branches coming off it, and they're all motor. Okay, so what are they? We have the flexor digitorum profundus. Those of you who remember the flexor digitorum profundus, we already mentioned that muscle that came off the ulnar nerve and did this. The flexor digitorum profundus has another belly that does this. Okay? It's the same muscle, it just has 2 bellies, and they're innervated one part, the medial part, by the ulnar nerve, and then this part, if you just remember this, you know, the okay sign, just remember the flexor digitorum profundus of these digits, the lateral digits, that's the first branch that comes off the anterior interosseous nerve. And then we have the flexor pollicis longus, which does this. So that's why I'm saying this is the movement. Okay. Now another movement that comes off, so this explains this, but there's another movement that the anterior interosseous does, and that is also pronation, the pronator quadratus. We already mentioned one pronator that is here. We have another pronator that is here. Okay. So there are 2 pronators and they compensate for each other. Okay. So those are the 3 muscles that come from the anterior interosseous nerve. Okay, so remember this or the okay sign. Are you okay? Anterior interosseous. It's affected. There's sometimes The pronator teres over here can push on it. There are other pathologies, patients who rotate a lot their hands, so if you use the screwdriver a lot, carpenters before electric screwdrivers have to use their hands a lot, so this can cause hypertrophy of the muscles here rotating. That can cause pressure on the nerve, and they can have, and then they're not okay. Remember, they're not okay. Another disease that can cause this is brachial plexitis. You may ask, well, this is not part of the brachial plexus, so why is it involved in brachial plexitis? Just because it is. Just take my word for it. Patients with Parsonage-Turner, brachial plexitis, ask them to do an OK sign, and very often it will be involved as well. All right, now, to finish up the median nerve, we have what's left. We have here intrinsic hand muscles. So that's a surprise, right? Because we said intrinsic hand muscles, that's a territory of the ulnar. Right? But those of you that litho, remember that there are 4 muscles. The acronym is LOAF, LOAF, that are innervated by the median nerve. Okay, so who knows what LOAF stands for?
Again. 2 lumbricals.
Okay.
It is
So the lumbricals are the ones that do this, the L shape.
Yeah.
Flexion, proximal flexion and distal extension. Okay, so L shape. Lumbricals.
and O is opponents pollicis
All
brevis,
of this does this. Opposition.
and A is abductor pollicis brevis.
Okay, so abductor pollicis brevis. Here's a movement that is a little bit surprising. Abduction here for the thumb is actually this movement. This is abduction, and this is the muscle over here. And this is the favorite muscle of EMGers because that's what we test when we test the median nerve. We put the electrodes over here. And what is F?
Flexor pollicis brevis.
Flexor pollicis, and this flexion. And the flexor pollicis actually has dual innervation. The other innervation is from the ulnar, so there's some redundancy. Okay, Loaf, remember that. Again, this is a question you'll be asked. So all intrinsic hand muscles are ulnar, except for 4, the loaf muscles. Okay. Now, why are they important? Because notice that they come into the palm of the hand. We're almost done. Come into the palm of the hand here under what's called the flexor retinaculum, which is over here. And this can push on the nerve, and the patient, if it's very severe, can have weakness of the loaf muscles and atrophy. So it's an atrophy of this muscle here, and they'll have difficulty in doing all the movements that were mentioned. So they'll have difficulty with opposition, they'll have difficulty with abduction, and they'll have difficulty with the nails. The most common pathology that will cause it is what's called carpal tunnels, right? So compression at the wrist here, which could be here's the carpal tunnel. Over here, are all squished up here, all the tendons. I think there are 9 tendons here. They're all squished up with the median nerve, which is the yellow over here. You can also see it over here. And if you do have carpal tunnel, then basically, if it's severe enough, then you can ask the surgeon to basically do a very simple procedure, your local anesthesia, basically open this, and usually the patient will feel better. There are situations where you don't do it, for example, in pregnancy, there's just swelling, and after pregnancy, the swelling goes away. Another example is hypothyroid. So if you treat the hypothyroidism, the swelling goes away. Another example is acromegaly. Treat the acromegaly. This I haven't seen get better that much because a lot of times the changes are fixed. Another example where you first treat the underlying cause is diabetes. But if you don't have any of those, and it's a classic idiopathic carpal tunnel, then you can send them to the hand surgeon and they'll treat it, and usually the patient will feel better. Thank you. So over this, any questions? Median, radial, ulnar, brachial plexus. Brilliant. By the way, I know this was recorded, but actually all these talks were recorded in the past and under the site, not the official downstate site, but the I don't even know what to call it, bootleg downstate site run by Ashley. You'll find recordings of those. So if you need to quickly listen through it, through the concepts, and I think I mentioned the most important clinical aspects, but also things that come up with see you next week. We'll talk about the overlay. Thank you.
Yeah, Dr. Perk. Ready?